Hello guys, welcome again. Today I'm gonna show you how a lower segment cesarean section is done. Come on, let's go. A 23-year-old Primigravida came with labor pains in 16 hours. She is referred from Peripheral Health Center for obstetric labor. On examination, BP is normal, pulse 120 bpm, patient is severely dehydrated. Uterus is term size, contractions are adequate. Blandrill's ring has formed. There is suprapubic flattening. FHR is 162, held at right flank. PV examination. Cervix fully dilated and effaced. Caput and molding are grossly present. Occiput is palpated at right occiputo-posterior region. Surgery is done by Dr. Paridhi and anesthetist Dr. Deepak. The incision given in this case is midline vertical to increase the area of exposure as there is obstruction of labor. Because in such cases, head will be impacted deep into the pelvis, bladder will be pulled up, there can be injury to bladder and there can be injury to uterine arteries as well. So if the exposure is good enough, it is easier to repair. Always remember, open layer by layer, because in case you accidentally encounter placenta previa or increta, accreta or percreta, you don't want to accidentally cut the placenta. Any surgery has to be done slowly and cleanly, possibly with minimal bleeding. Now the rectus sheath is being cut with scalpel, and now that you can see, my friend is opening the parietal peritoneum with blunt dissection. See, the pinkish thing which you can see through the abdominal cavity is the uterus with fetus inside. Now my friend is dissecting uterovesical fascia, the fascia between uterus and bladder, to send the bladder down to incise the uterine lower segment. See the color of liquor. It is not straw colored. It is yellowish in color. It is meconium stained liquor. As the head is deep into the pelvis, my friend is taking out the shoulders first, anterior shoulder and posterior shoulder. Then the assistant is giving fundal pressure gently. Then she is taking out the trunk, hip and the legs, and followed by the head. This technique is called Patwardhan technique or reverse breech extraction. Here she is doing early cord clamping because the liquor is meconium stained and the baby is in distress and need immediate neonatal care. And now comes active management of third stage of labor, that is AMTSL. The cord traction should be in a controlled way, followed by uterine counter traction. Place the Doyne's retractor again to retract the bladder. Hold the uterine angle edges with Alice forceps. Now the uterus is being stitched with number 1 picral sutures. Always remember, the stitch is taken half centimeter away from the uterine angle to include any major bleeding vessel, possibly uterine artery. Always include all the layers of the uterus into the stitches to prevent a later complications called caesarean scar niche. Caesarean section, if properly done, will not take more than 45 minutes, but time should not be the main priority. Main priority is to be slow and steady with possibly minimal bleeding. Always close the uterus in double layers, again to prevent a complication called as caesarean scar niche. As there is little bit of hematoma formed, it is being repaired with Vicryl 10. Always inspect the uterus posterior wall for any hematoma and insert the uterus back into the abdominal cavity. Inspect the stitch line for one last time before closing the peritoneum. We are inserting something called as ab gel to absorb any oozers from the uterine stitch line. Now the palatal peritoneum is being closed with again Vicryl number 1 suture. The rectus sheath is held in between two Alice forceps and is being stitched in continuous form with Vicryl number 1 suture. This is how lower segment caesarean section is done by midline vertical approach and by Patwardhan technique in case of obstructed labor. If you liked my video, kindly like, comment and subscribe for more of these. Thank you very much.